All right. Good morning, everybody. Thank you so much for joining us today. We've got a great conversation for you. I love your support in getting the word out about this live stream by sharing this live stream with your networks, with groups that you're involved with on social media, and just doing your best to help us spread the word. We've got a great conversation coming to you with Tim, who is here with Eugene from Eugene with the White Bird Clinic. And before we give him the mic, we're just going to do a quick introduction of who it is that you see on the screen, and then we'll get going. So, Micah, would you like to start us off?
Yeah, my name is Micah Schwantner. I'm a local, I guess you could call me a concerned citizen, and I'm very interested in educating the community about the opportunity that the CAHOOTS model as administered by the White Bird Clinic poses for a place like Northern Arizona. As many of you might know, currently the city of Flagstaff is considering sort of like alternate responses to emergency services. And as they develop sort of like what they would like to see in that area, I thought it'd be important that we get sort of like models that have been successful in other places in front of the community so that they can have input on what they'd like to see coming from sort of like their elected leaders.
Thank you, Micah. Jonathan, why don't you go next?
Yat Ebene, my name is Jonathan Yellowhair. I work at an agency in Flagstaff called Native Americans for Community Action. Here I work as a substance abuse counselor and do groups with mandated clients for all sorts of stuff, DUIs, CPS cases, domestic violence cases. And yeah, I love my work, so I'm super excited. I'm always excited to hear about people's agencies and the work that they're doing. And I think it's really awesome to be here and to learn. So definitely excited to be here.
Thank you, Jonathan. And last but not least, we have Tim Black with the White Bird Clinic, who is the outreach director. Tim, why don't you introduce yourself?
Thanks, Adam. So my name's Tim Black. I use he, him pronouns. As Adam said, I head up outreach and consulting for White Bird Clinic right now, really supporting other communities like yourselves as they have these conversations around what does mobile crisis really mean, what else is lacking from our systems, and how can we separate these responses from, really traditionally being handled by law enforcement. Prior to the work that I do right now with White Bird Clinic, I did serve first as a crisis worker on the CAHOOTS van going back to 2010 when I started with the agency. I've also served as a operations manager and coordinator for the program, and have overseen several of our expansions. So I'm really excited to be talking with you all today, and really, trying to touch on both the experiences that our responders have out in the field, what it's like as an administrator to try and oversee these programs, and what it really means to, engage with a community to provide community-based crisis response.
That's great, Tim. And again, thanks for being with us. Tim, we'll let you go ahead and dive into your presentation. For folks tuning in, what we're going to do is we're going to let Tim present to us about their model and what they're doing. And then we're going to take questions from the panel and then questions from you, the public. And so please put your comments and questions in that chat box. But Tim, go ahead and take it away.
All right, thanks, Adam. All right, let's go ahead and see if I can still share a screen. Nope. Okay. Doesn't look like screen sharing is working for me, but you know what? We can do this. We can do this. Just give me 1 second.
Yeah, take your time. Let's see if we can get that working for you. Do you see the button at the bottom, Tim?
Yeah, and I've got to share screen, and it's just, there we go. Hey, all right. Sometimes things will work for us, huh?
Sometimes.
Yeah. All right. How's that looking for everybody?
I don't know if I see that. I do see this. Okay, there we go.
All right. So before we start talking about the CAHOOTS program that we have here in Eugene-Springfield, it's important to really recognize the larger organization that really, founded the CAHOOTS model and continues to serve our community, and is really the reason that CAHOOTS is as successful as we are. Whitebird Clinic is a fairly qualified health center that staffs not just the CAHOOTS program, but other crisis services. We have outpatient behavioral health care, including counseling, individual and group recovery treatment, which includes medication as an option for treatment. We have a medical and dental clinic. And then we have case management and all sorts of peer support and systems navigation services. But regardless of what it is specifically that somebody is accessing through a Whitebird Clinic, all of our services are oriented around these four philosophies. One is that we are client-centered, that everything we're doing is really oriented around the experience of those that we serve in the community. We utilize a harm reduction model, which is really important, especially when you consider our outpatient recovery programs, really coming in and not mandating abstinence right out of the gate, but recognizing that, recovery is a journey, and that there are going to be missteps or, shortfalls and triggers, and that we need to work together to reduce the harm before somebody is ready to abstain from something, whether that's a maladaptive behavior or a substance. And if abstinence isn't part of their plan, then that's not going to be part of, what the treatment is pursuing. We also really recognize that we need to be trauma informed in the services that we provide to our community. That really means recognizing how, accessing services, what's that point of entry look like? How is it that we're interacting with people? Are we asking them to re-traumatize themselves and give us the full story every time we meet them? Or are there ways that we can empower them to really help us document that story in a way that authentically portrays their experiences and allows them to really pick up where they left off the time before? And finally, we operate as a collective. We have over 250 members, and we utilize consensus for all of our decision making. And actually, this last point around being a consensus-based collective is really important, because if we're going to do that effectively, that means that being client-centered, utilizing harm reduction mentality, and coming from a trauma-informed framework are necessary components of how we interact with each other to operate the business side of things. And that really means that we're practicing this work day in and day out in order to serve our clients better. Specifically within the CAHOOTS program, which is what we're here to talk about today, our staffing model is always going to be a crisis intervention worker and an EMT. Going back to when our program first started in 1989, our initial funding, the initial contract even outlines that we have an EMT basic or higher and a crisis intervention worker. Our crisis workers don't need to have a master's level credential. In fact, we've actually seen that folks are more successful when they're coming from a place of lived experience, either as a credentialed peer support worker or somebody who just, has had friends and family that have struggled, or they themselves have had adverse experiences over their lifetime. It's really about, what is it that's going to make you the best fit for this work, which is really, unique and challenging first response work. Regardless of what kind of a background somebody comes to the CAHOOTS team with, everybody's going to go through about 500 hours of field training and spend 30 hours in the classroom. In that classroom time, we're really digging into a lot of the logistics of being a CAHOOTS responder. How do you use a radio that's shared with other public safety systems? How do we approach verbal de-escalation and compassionate communication? What does harm reduction actually look like when you're working with somebody in the field? And something that's really important too is how to work with those other traditional public safety systems. And as a crisis worker or an EMT, how do you support the other person in their role to make sure that, every interaction that we have, every intervention is humanistic, is really centered in the lived experience of the folks that we're serving. Our responders are always unarmed. That means that we're not wearing vests, we're not carrying pepper spray or a taser under that rain jacket. We really are relying on verbal de-escalation for everything that we do. And that de-escalation that we do even really starts before we've interacted with somebody. And I'll touch on this again a little bit later on in my slideshow. But, as you can see here in this image where two of our responders are talking to this man seated in the chair, we don't look like traditional first responders. You compare the beanie and the hoodie that the gentleman squatting down is wearing with the officer and the other picture on the right, and those tell two very different stories about who it is, what kind of authority and what kind of resources are available to that authority and that come with that power in those responders. When we show up in a way that isn't the same as police, and when we look different from those other traditional public safety systems, we're able to have a lot safer interactions with folks because they know their civil rights aren't at risk of being taken away just because CAHOOTS is talking to them during their hard day. And the final thing that I really want to bring up at this point in the presentation is really that our work is about supporting and stabilizing somebody in the field in that moment. Having the CAHOOTS team show up and expect that we're going to be able to get somebody medicated, housed, get them enrolled in food stamps and get their social security application submitted, processed, and approved. That's just not a realistic outcome of the work that we can do. But what we can do is find ways to support folks either where they are in the community or through connections to other services to at least find some stability in the moment, to be able to respond to that most emergent crisis in a way that allows for exploration of other resources that can prevent those triggers, prevent those situations again in the future. And that really means employing least intervention necessary. What that really means is recognizing that sometimes inflicting care can be even more harmful than accepting that somebody just isn't ready to work with you on what we as outsiders have identified as a need to be met. We got to talk about the pot of gold at the end of the rainbow, though, before we really move in any further in this conversation. That's to really understand how our program is currently funded, what resources are available to us. Right now, the CAHOOTS program receives about $2.2 million a year in revenue, and that allows us to operate 60 service hours per day. That means that in a given 24-hour period, the two cities that we operate in are each going to have at least one van responding to calls 24/7. In the city of Eugene, which is the larger site of our population center in our metro area here, we have a secondary van that comes on for 12 hours a day. And that's how we get to that 60 service hours. In the city of Eugene, where we've been running for the full 32 years now, all of our services are funded by the city of Eugene. And that means that the city identifies an amount that the Eugene Police Department is then allowed to spend on mobile crisis services, and the Eugene Police Department contracts with Whitebird Clinic to provide the CAHOOTS response. In the city of Springfield, which is just across the river from Eugene, the inspiration for the Simpsons City of Springfield, it's a smaller community, which means that there's a smaller tax base and ultimately a smaller budget for the city to work with. In that city, what we've been able to do is merge a combination of city funds with county health and human services grants to be able to provide our mobile crisis services. It's also really important to recognize that this $2.2 million that we receive in revenue isn't really sufficient funding for the services that we provide. We're not able to pay our responders wages that are commensurate with other public safety systems. We're not able to offer a retirement plan match or provide insurance for family members and dependents. And so we are really working with our funders. And, every time I have this conversation, it's really important for each community to consider that not only is this a necessary component of public safety, but in providing these services, we also really need to ensure that the responders are being adequately compensated and that this program itself is receiving the support that it needs to be the best that it can be out in the community. Part of our 2.2 million that we receive also comes not just from the cities of Eugene and Springfield and from Lane County Health and Human Services, but also from Medicaid wraparound service funding payments. And that's something that we can talk about a little bit more after I get through this presentation. But this is one option that was really the inspiration behind Senator Ron Wyden's CAHOOTS Act, which is working its way through committees right now in Congress. And so you can see on this slide, here's our budget breakdown, where that 2.2 million comes from. We've got 850,000 that we're receiving from the cities of Eugene and Springfield, about the same amount from Lane County. There's that 46,000 from Medicaid. But then there's also $500,000 a year that we have to do in fundraising and philanthropic work. And that really represents our efforts to respond to the needs of our community. It's not just gas for the van and paying salaries to train new staff. It's also really making sure that when we go out and respond to somebody, that we can really provide them with what they need to find that support and stability that night, whether that's a tent, a sleeping bag, access to some food, or with us having one of the highest rates of homelessness per capita in the United States, with inadequate shelter resources in our community, we are sometimes covering the cost of a hotel room because that's what it's going to take to really get somebody into a better situation that night. In addition to this 2.2 million that we receive in revenue for our operations, there's also about $250,000 that goes into the cost of maintaining our vehicles for our fleet, and for using the public safety answering point. That's the larger public safety dispatch system. Those are all indirect costs that we're not paying for, but that are all part of what it takes to really run this program. And as I said earlier, I'm going to say this again probably before we're done here, the current funding that we have for this program isn't sustainable. There isn't a reflection of the cost savings that we are achieving for our community through diversions in the ER and in the jail and criminal legal system that aren't reflected in the support that we receive from our communities. And really, what it comes down to is that until we're able to receive that kind of support that we need, recruitment and retention are going to be impacted. It's going to be harder for us to pay the kind of wages that we would like to really recognize the fact that our responders are serving, a really unique and under-recognized component of public safety, which is that behavioral health first response. So as you all in Flagstaff are really talking about what it's going to take to bring something like CAHOOTS to your community, this is something that really needs to be front and center in all of your conversations. This is an area where, we encourage communities not to make the same mistakes that we did by historically taking really low bids and, really undervaluing the work that was being done by everybody that is part of this response. What do we do is another really big question, and understanding the full scope of the response that CAHOOTS provides is really key to, I think, contextualizing our role in the public safety system here in Eugene and Springfield in Oregon. We do crisis counseling, that's a given. It's right in our name. CAHOOTS is that acronym for crisis assistance, helping out on the streets. But we do a lot more. We do not just prevention and intervention work around suicide. We're also present for a lot of postvention activities, which could include supporting family members on scene, prior to the arrival of the medical examiner or the coroner. We do a lot of conflict resolution and mediation with families, between roommates, and this actually serves as a homeless prevention tool. If we can find ways to address, for instance, the conflict that roommates may be having, that could potentially keep somebody housed and avoid a situation where they're getting kicked out of shared housing. We do a lot of work around grief and loss support, and that includes death notifications. In our area, rather than having an officer come out and tell you that a family member or a loved one in a different city has died, it's CAHOOTS who's coming out and providing you that information, and then really being there with you to evaluate other resources that you might need, or just to kind of process that grief and that loss in the moment. We do the majority of welfare checks in our area, particularly those for what's called a subject down. And that's really anybody who's not up and moving around and is out in a public space. If there's somebody who appears like they're really intoxicated, that call is going to be routed to CAHOOTS unless there are signs that there's a medical emergency. Somebody who may be sleeping in a park is going to get woken up by CAHOOTS instead of a uniformed officer. We do a lot of work around substance abuse, and this includes not just kind of talking with folks about addiction or their use and abuse, but also really supporting direct admits to sobering and detox. And this is one area where we can really accomplish a lot of diversions from police interactions by being that response for folks who are out in the community whose intoxication is really preventing them from being able to care adequately for themselves or maintain the safety of the community members around them. We respond to a lot of housing crises calls and either connect folks to shelter or work to identify other ways that we can get somebody out of the weather for the night. I do a lot of work around harm reduction, whether that's with regards to substance use and abuse. It could be self-harm, self-injury, other maladaptive behaviors or coping skills. We try to take that harm reduction approach, as I mentioned in my first slide. By having EMTs as a part of our response, we're able to do a lot of first aid and non-emergency medical care. And this is actually an area that allows us often to have our first point of contact with somebody. For folks who may be, for instance, living in their car and they just had foot surgery related to their diabetes, maybe it's challenging for them to get to a wound care clinic, but knowing that they can call CAHOOTS and have a medic come out and check their suture, say, hey, things are healing up, or no, we need to get that checked out by a doctor, can provide a lot of reassurance and is a way for us to build rapport and trust with somebody before they're comfortable really kind of talking with us about other behavioral health experiences that they might need support with. There are plenty of interactions that we have with folks in the community that are really just around looking at that overwhelming multi-page list of resources, and trying to figure out which food box is actually the closest, pantry location. Where is it that you can actually get a shower and a meal? Where is the laundry facility? How do you get to, the case management office? Really just kind of trying to take those overwhelming documents and experiences and boil them down to specific action plans. And sometimes that means even connecting folks directly with those services by giving them a ride. A big difference between law enforcement and the response that CAHOOTS provides is that if an officer picks you up, generally speaking, they're going to be able to take you to jail, detox, maybe a crisis center, or the hospital. But CAHOOTS teams are really permitted to transport to any sort of facility that's staffed, open, and appropriate for the situation that we're working with somebody on. So, we take a lot of folks to pantries, to the basic needs center to get showers, to drop-in hours at the case management office, really whatever is necessary to, again, provide that support stability. We also do co-response in a lot of situations with other traditional systems. I've highlighted on this slide our co-response for intimate partner and family violence experiences. These are a situation where law enforcement really likes us to have come in and support folks after an arrest has been made. In particular, one thing that we're able to do really quickly and efficiently is help get folks connected with those, intimate partner and family violence resources, being a third party that can help get somebody to a private, secure location so they can meet with that intake worker and get access to a shelter. As an area where we can provide that support and really allow officers to focus on what they are, asked to do in those situations. But there are plenty of other, hypotheticals that we could dive into, and I'm sure that some of that will come up for us as we discuss with the panel after this presentation. How you access CAHOOTS is really important to talk about. Everything that CAHOOTS does is dispatched by the public safety communication system. You'll hear me and others probably as you engage in other conversations around this kind of reuse the concept of PSAP, and so that's public safety answering point. So in Eugene and Springfield, when you call the public safety system, the phone tree is going to tell you press 1 for police, press 2 for fire or EMS services, and press 3 for CAHOOTS. We recognize that our founders really created a system that is reliant on privilege in order to access CAHOOTS. You have to be safe enough in calling a public safety number that could also get you connected to police or paramedics in order to access CAHOOTS. We recognize that we're making that ask of folks and really demanding that privilege be something that you consider as you're accessing us, and as such are engaging with our community now to find other ways that are less oppressive, that will create better access, that will be safer for folks who feel like calling the public safety system just isn't going to be a safe outcome for them. We really recognize the privilege that our founders had and are actively trying to, confront and address that. This is what our system is right now, though, and so I do want to kind of explain for consideration and for you all to think about, maybe what an alternative looks like based on how we do things here in Oregon. All the calls for service that are coming through the public safety system are going to be triaged by call takers and dispatchers. So that means that everybody calling in about that car crash on the highway, calling in about the person shouting in their encampment, and the person, calling about a bank robbery, those are all going to the same folks in the same call center who are trained to really look at everything that's coming in and identify what the most appropriate resource is. Whenever it's possible to identify CAHOOTS teams as that resource, we're going to be dispatched on non-priority police channels, but over the same public safety communication system. So that means that other traditional resources are aware of what we're doing, at least the address that we're going to for an intervention. And so when we, in rare occasions, do need to call for that support, either from police officers or from, paramedics or the fire departments, there's already an awareness of what part of town CAHOOTS is in. Maybe not who we're talking to or what it is that we're doing there, but that, we're on the west side of downtown. And so officers who are doing the west side of downtown beat should be listening on the radio in case CAHOOTS calls and requests cover. This slide really shows how we fit into that larger system and kind of what we're considering as our workflow. Kind of starting up on the top left here, we have a crisis occurring and then a call is placed to that public safety answering point. That's that PSAP. Call takers and dispatchers are working together to identify what the service need is, and then are dispatching a first responder. That could be fire and EMS, that could be police, that could be CAHOOTS. The majority of our responses occur without those other traditional systems in place. If fire and EMS or police show up on a scene and it's more appropriate for the mobile crisis intervention system, CAHOOTS, to respond, those resources can tell dispatch, this needs CAHOOTS instead of us, and then we'll be routed out to respond to that call instead. When our teams arrive on scene, our initial objective is that de-escalation and assessment. What is it that's going on? How can we be of best support? And if we've identified that we can resolve this on scene, then we're going to be looking to accomplish that resolution in our intervention, providing in referrals that somebody needs, the next time that trigger comes up, or to continue to maintain stability. And then, as I said, we are also considering transport. And if we are going to be giving somebody a ride, generally they fall into 3 buckets of hospital is a 24-hour resource, shelter, or other brick and mortar service providers. Each destination that we're taking somebody to is going to be including a transfer of care as part of our work. We're going to actually document a little bit of information about what we did, what the person in crisis told us, maybe if we took vitals, what those were, if it's relevant, maybe a medication list, so that when we get to that other facility, to that other resource, we're supporting the person in crisis by really helping advocate for them. And, as I mentioned earlier, not asking them to re-traumatize themselves from telling their entire story over every single time they interact with a new provider, through the course of our intervention. And what does that all mean? What does all this kind of conceptual stuff actually look like out there? How many calls are we taking? What's our impact in the larger system? And so I'd like to spend on this slide some time talking about our response numbers just in the city of Eugene. And I'm using the city of Eugene as an example, in part because we have been there for 32 years. In Springfield, we've only been serving over there for the last 6 or 7. And so we haven't had as much time with that community to really build up this model. But Eugene really represents, long-term, what kind of impact these systems can have in those more traditional public safety response. In 2019, in the city of Eugene, the public called dispatch 105,000 times. 18,000 of those calls that were placed to our dispatch center in Eugene resulted in CAHOOTS being involved in the response. That means that, sometimes we were showing up alongside police, either because of the ambiguity of the situation or the severity, or we're showing up with the fire department or an ambulance because it's a really complex and complicated situation. So CAHOOTS went out in the city of Eugene in almost 18,000 calls in 2019. We did 15,000 of those calls without traditional responders accompanying us. So that means 15,000 calls without an officer in uniform or in a patrol car, 15,000 calls without a fire engine or an ambulance showing up alongside us. And out of those calls that we did, 13,000 of them would have required that there be an officer or paramedic or a firefighter on scene. That's huge. 13,000 of the calls that we're doing that would have required other systems to respond if we hadn't been available. And the Eugene Police Department estimates that through those 15,000 calls that CAHOOTS responded to as the sole response intervention, we have an arrest diversion rate of 5 to 8%. That's pretty big on its own. But then what I've heard both from the chief of police, but also patrol officers, is that when you think about the fact that we're taking almost 18% of the overall call volume from the public safety system, but having that arrest diversion rate of 5 to 8%, there's a huge percentage of our calls that are such effective at prevention that they haven't even gotten to the point where they could be counted as something that would have otherwise resulted in arrest. Our community really knows to call us before things get so bad that there's going to be that police interaction, or before they're going to need to go to the hospital. And out of all of that work that we did, we only called for police cover 311 times in 2019. That's out of the 18,000 dispatch calls, or those 15,000 that we took on our own. Less than once a day are our teams calling for police support because the situation has really escalated. And it's a pretty even split in those situations between violence and aggression and what we call a POH, which in the state of Oregon is a peace officer hold. That peace officer hold is going to be for somebody who needs connection to a higher level of care, but for whom we're only going to be able to connect them on an involuntary basis. So that person who really, is a danger to themselves or others and is totally unwilling to go voluntarily to the hospital, or somebody who is so heavily intoxicated that if we leave them where they are in their community, they could fall and hit their head and get a traumatic brain injury, but they're still unwilling to go with us to lay down and sleep it off for a few hours. And we can talk more about specifics, when we get to the panel part of this conversation today. I want to dive into a little bit more detail around our emergency room and our criminal legal diversion numbers. I'm not going to go through every bullet point on the slide, but I do really want to recognize that, we have probably the largest impact on the community with regards to cost savings when it comes to those ER diversions. A lot of that has to do both with our harm reduction abilities, but also by having that EMT as a part of the response. A lot of situations where somebody could go to urgent care or just really needs support wrapping that abscess of the head drained with some fresh gauze. There are a lot of situations where by responding and providing more appropriate services, we're preventing folks from going to the ER because other services aren't available. Or by providing something that's more social in nature to the response, we're addressing the isolation and loneliness that some folks are trying to take care of by going to the emergency room, where there's somebody who can fret over them, worry about them for a couple of hours, which is a change maybe from an otherwise pretty lonely life. What that turns into is almost $15 million a year that we're saving our community, through both medical and behavioral health responses, through diversions to ambulance rides, even if they ended up going to the ER anyway, and from those that we've diverted from the emergency room entirely. That's $14.8 million that we're saving a year. And that's on a program that receives $2.2 million a year in revenue. If we look at just the numbers for those who would be covered by Medicaid in our area, there's a cost savings to Medicaid alone of $4.1 million. Then there's also our criminal legal diversion. The Eugene Police Department estimates that we save $2.2 million a year just in officer labor. And then when you look at our arrest divert rate of 5 to 8%, you can start to speculate, with those reduced court dates, with those bench warrants that aren't being issued, with fewer jail beds being needed, that number just starts to increase dramatically. But as we have seen with, police departments across the country, it's been really challenging for us to get any more specific as far as, even an estimate around kind of the larger cost savings. We understand, police departments want to be protective of their budgets, but at the same time, we really need to be able to paint the full picture of what it's costing communities by not having responses similar to CAHOOTS in their areas. Through all of the work that we've done over these 32 years, we've never had a staff member seriously injured as a result of patient contact. There are the occasional scuffles and bumps and bruises, but we've never had a shooting, stabbing, electrocution, anything of that nature. And that really exceptional record that we have with worker safety really boils down to these concepts and these are components of our training of, really having, a high degree of situational awareness, what's going on in the scene. One of the questions that comes up a lot for our trainees is, when we're responding to somebody who's in a public space, is that public space itself a safety issue that needs to be addressed? Is there an audience that could potentially trigger the person in crisis? Are there folks who may be expressing their bias against somebody because of their race or ethnicity or housing status? And is it going to be safer for that individual in crisis if we take them somewhere else so that we can remove them from an unsafe, kind of public situation? We need to have really clear communication with our shift partners. We need to be able to communicate on that radio. Something that folks don't really consider when we're talking about mobile crisis is, especially if it's a 24-hour program, man, folks are going to get tired and you got to drive around, a lot. It's mobile. That's the mobile part of mobile crisis. And so defensive driving is really important to the work that we do. I mentioned this before, and I think this is the one that I'll spend the most time on in this slide, which is really around our appearance, the gear that we carry with us when we are talking to somebody. As you could see in those earlier slides, it's kind of the traditional CAHOOTS responder uniform is going to be a t-shirt or hoodie with a logo clearly emblazoned on it, jeans and some work boots. If the weather's nasty, we're going to toss on a kind of a heavy duty like Carhartt rain jacket, but that's really it. We try to avoid having a belt that's got a bunch of little tools on it, even if that is a pouch of gloves and some trauma shears and a multi-tool and a flashlight. If you have a bunch of things on your belt and you're trying to walk up to somebody who maybe just woke up and trying to rub the sleep out of their eyes, or they have other visual impairments, seeing that belt with a bunch of things on it could be a trigger to say, oh, hey, is that an officer? Is this police? Is this something that I need to be worried about? By having really kind of dark clothing with a high contrast logo on the chest that has the Whitebird Clinic logo larger than any font, we're not asking somebody to read. We're asking somebody to recognize a logo that's already associated in our community with other services and with other humanistic resources. Self-care and clinical debrief are really important. And so really making sure that our responders have time to talk about not just complex cases and do that kind of case management in our meetings, but also really talk about how the work is affecting us. When I was a responder, on a weekly basis, being able to go in the staff meeting and say, I noticed that I'm transferring a lot of, my personal baggage around, this issue onto folks in crisis that are experiencing something similar. What have other folks done to address that transference? That's a really, really awesome opportunity to just kind of talk about the stress and the vicarious trauma, that we encounter as responders. Self-care also really means destigmatizing access to therapy as responders ourselves. And this is, I think, one of the single biggest successes that CAHOOTS has had in self-care in recent years is really kind of shifting the narrative and getting to a place where it's encouraged and almost expected that as first responders, we are supporting ourselves and taking care of our own needs by accessing therapy in addition to, staying hydrated, being engaged in hobbies, spending time with loved ones. And then finally, intuition and verbal de-escalation are just so tantamount to the safe and effective interventions that we have, day in and day out. One of the other things that I think is really important to recognize is that inherently mobile crisis teams are going to be out in the community, talking with folks in positions of need, confronting the realities of the shortcomings of a larger system. There is this joke that is far too accurate about CAHOOTS here in Eugene and Springfield, and that's that our community doesn't have a safety net. We have a bunch of hammocks, and CAHOOTS is running around like a needle and thread trying to stitch those hammocks together, even if just for a night, so that we can get something better for somebody. Being a mobile crisis responder inherently means doing a lot of patient advocacy, and we have an obligation to use our privilege of that, insight into how the system is working and isn't working by being a part of advisory boards and other collective impact or collaborative conversations that are happening in our communities, so that we're, one, making sure that we're really represented, but more importantly, the needs of our patients, the needs of the community are being represented. And so that's where you'll see responders from CAHOOTS representing the team and representing Whitebird Clinic as an organization at various care councils, summits and other boards that occur in our community on a weekly, monthly, quarterly basis. And that really allows us to stand up and support other systems. The success of mobile crisis is predicated entirely on what else exists in a community. And so we, again, I use this word a lot, but we have an obligation to really do everything that we can. And that includes speaking up and being a part of these larger discussions. Because if we don't have a seat at that table, then we're worried about the voice being missed or disregarded completely. And in one area where that has really come to fruition is around housing. As I mentioned, Eugene has one of the highest rates of homelessness per capita in the United States, according to HUD. And that means that our congregate shelter isn't enough to house the nearly 4,000 folks who experience homelessness on an annual basis in our community. That means that for a short-term housing crisis, we've had to get creative. There's another organization in town called Community Supported Shelters that builds these huts. It's about 60 square feet of living space. You can fit a single bed in there comfortably. A double bed is a little cramped, but this is insulated. There's electricity. This is a locking door and a stable place for somebody to stay for a few months while they work their way through a wait list or kind of go through surgery. And so really responding to these needs, we found a lot of success in partnering with the Eugene Police Department, where PD funded the construction of these huts and then CAHOOTS oversaw referrals and placements into them. and it's improving outcomes. It's allowing folks, as I said, to recover from surgery, to have stability and support, be in the same location on a nightly basis. So maybe an assertive community treatment team can come in and find them because they know that, this person is going to be in the hut at the fire station, or this person is in the hut at the parking lot of the church downtown. It's been a really awesome and powerful way for us to work with the community to house our neighbors. We also have a couple other partnerships that I want to highlight and encourage you all to think about with regards to housing specifically. Is Shelter Care is a family housing program that has studio apartments, where CAHOOTS has a couple that we reserve and just kind of keep free for our use, where we can refer families to have some shelter. We've really seen that allows in full integration with another provider. That means that maybe the initial access point is Wiper Clinic and CAHOOTS because that crisis is happening in the middle of the night. Then we take you over to the shelter care unit, get you lodged there, get you set up for a 3-week stay. And that allows you time to intake with shelter care, kind of start to work with their team and identify what housing resources shelter care has available that might be more appropriate for a long-term placement. So we've had to get creative to really, as I said, kind of meet the needs. And so, as you all in Flagstaff are really considering what mobile crisis in your area is going to look like, I really encourage you all to really think about this area of collaboration and what are some of the other needs that maybe a mobile crisis team is going to shine a light on, and how can we use that privilege of response in the moment to accomplish better outcomes. And finally, this is the last slide I'll bore you with right now. The reason that I'm talking with you all in another community other than Eugene-Springfield is that over the last year and a half, Wiper Clinic has really made a commitment to supporting other communities as they explore what mobile crisis services mean for them, and as they work to define and build programs that are really unique and nuanced to the needs of each community. We do these types of presentations, but we also do a lot more direct technical advisory support, and have helped with program design and implementation, or training and education for responders in Denver, Colorado for their program. We've worked closely with some programs in the Bay Area, Portland, Oregon. Oh gosh, who else? We did some work with Rochester, New York, and right now we're working with communities in Canada and the US to really move forward together in this objective around providing a trauma-informed response and really eliminating police as an option for mental health response. The last thing that I'll mention here is that funding is a big part of this, and we're excited to see how things play out with the CAHOOTS Act, which Senator Wyden introduced. The funding for the CAHOOTS Act was allocated and approved through the American Rescue Plan Act. And so what we're seeing right now is that a lot of the rules and regulations are being worked out by a couple of different committees in Congress. And we hope to see that turn into actual programs in communities like yours, in the coming months. So I know that there's probably a lot for us to discuss, and I would love to turn this over to the panel so that we can really kind of dive into more around, what does this mean for the Flagstaff community?
Wow, Tim, thank you so much for your presentation, and congratulations to you and your team on all the success and all of the recognition across the nation and internationally too. It's been incredible to witness this past few years, and you all really becoming a household name in many communities. It's really exciting. Panel, let's start off with some questions from us. There are some people tuning in that have put questions in the chat section of the live stream. Folks, if you're tuning in and you have some questions that you'd like to ask, please put them in the chat. I've got a list of questions, but Jonathan or Micah or Daryl, who has joined us, do any of you have any questions that you'd like to ask at this moment?
I can go first. First of all, I really like your terminology. I like what you said about inflicting care. Like, I never heard it put that way, but I absolutely agree with that. I like that a lot. I think that's something that we try to avoid here at our organization. I just never heard it put so eloquently. So I'll definitely be stealing that and saying that I
Please do. Yeah.
that I started saying that. That's my saying. So just kidding. So a question I had in regard to the care aspects. I know here in Arizona, we're still very abstinence based. And so but I'm all about, harm reduction. And so I'm wondering, how did y'all navigate that pushback in regard to harm reduction, and kind of deviate away from that abstinence-based aspect? So.
Yeah, I think that we're really fortunate that Whitebird Clinic has always really maintained a harm reduction mindset in its more traditional brick and mortar resources. Our founders spent a lot of time with the Haight-Ashbury Free Clinic and really learning about that approach and that model, and tried to emulate that with our crisis center and our other facilities. And so there was, I think, a really natural philosophical migration over to our mobile responses as well. But that doesn't mean that it was easy. We had to really convince our funders that this was necessary and appropriate. And one of the things that we were able to really latch onto with police specifically was that in nearly every single one of these cases, that substance abuse that we're encountering as first responders is about some other trauma, and is ultimately about public health issues. And that if we can maintain that approach and really look at this as a public health response and not an enforcement response, then it becomes a lot easier to get to that place of harm reduction. I think we're also really, got to recognize that there is a pretty liberal bubble here in Oregon. We did decriminalize, personal use possession in the state of Oregon this past fall. And that is, I think, part of the legacy that our state has had around, I think, being more tolerant of something other than an abstinence only push.
Okay. Yeah, thanks for that. And yeah, because it's the same thing here, there's grants that get denied, like failure to access funding, because people really are nervous about the aspect of harm reduction services.
Yeah.
And so, but I mean, it is changing. We're even looking at implementing MAT here at my work. And so it is changing. But I was wondering, because of course, with what we want to do, I think that could be a key piece of it as well.
Yeah.
Especially when working with the unsheltered relatives that we do. I think it'd be cool to take more of that approach of harm reduction, but there are a lot of barriers. So thanks for that. I appreciate it. And
absolutely.
Great presentation, spectacular.
Yeah, thank you. Yeah, MAT is one of the approaches that's one option available to folks accessing our outpatient services, and I've seen some just tremendous successes. And so personally, I'm a huge advocate of MAT.
Oh yeah.
Thank you for that, Jonathan. Micah, did you have a question you'd like to ask at this point?
Yeah, thank you so much, Tim. That was a lot of information and a whole lot for us to think about. Really quickly, I'd love for you to kind of go back and talk a little bit more about sort of the advocacy work that you do, and specifically how referrals work with other resources. Like, what diversion resources are there in Eugene? Because a problem that we face in Flagstaff is that a lot of our resources are both underutilized by vulnerable populations and also stretched very thin with the people who are actually utilizing them.
Yeah. A couple of our I think biggest collaborators in diversion services are our detox and sobering center, and then a lot of our street medicine, and kind of street medicine based services. With regards to sobering and detox in our community, if somebody needs sobering services, they're actually going to a facility run by a nonprofit that has connection to a detox facility that's just on the other side, but also inpatient and outpatient recovery services. And so CAHOOTS teams, because we have that EMT on board, we're able to do an eval out in the field, fill out the assessment paperwork, and then take somebody directly into a sobering bed. That means that, for one, there's less likelihood that an officer is going to be getting involved with them, and that could potentially result in an arrest, as opposed to officers mandating a hold for them at the sobering center. It also allows the individual to really kind of stay in control of their situation. Street medicine really helps us in diverting folks from the emergency room, because we can work to get folks connected to those other ongoing supports. Calling for CAHOOTS means that you're kind of waiting for whatever else is available for us, and maybe that could mean that by the time we actually get out there to you, that things are pretty bad and you need to go to the hospital, right? But if we have connection to the street medics that are working, doing their outreach, we know that on Tuesdays and Thursdays, they're going to be, in the encampments near the wetlands, and that on Mondays, they're at our downtown core encampment. We can work with folks to say, okay, so if you're going to be, you're camping downtown, it's Sunday night, street medicine is going to be at your location tomorrow. Let's work with with you to kind of get set up with them. We have a really great medicine program that started as street medicine, has now become brick and mortar. That was born out of the Occupy movement. And so a lot of groups like that are really oriented around, mutual aid, really being able to respond to medical needs free of charge. And then having access to that sobering and detox facility are the ways that we really keep folks out of the jail and out of the hospital system.
And do you also provide advocacy services for people, sort of like post-crisis, navigating the different services that are different resources that are available in Eugene?
Whitebird Clinic can do that. CAHOOTS really, I think it's good to think of us as, kind of like the paramedics, right? And that's not actually that far of a line to draw. But, you think about the fire department, they respond, right? They're going to help you set that leg, get you to the hospital, but then you're going to go need to talk to a doctor after that. And with CAHOOTS response, we can just de-escalate and intervene in that immediate crisis, but then we're going to be looking at what is it that you need ongoing? What is it that you've identified as a support that would be helpful for you? And if case management and further advocacy is part of that, then we're going to want you to talk to the Whitebird Clinic case managers. We're part of the same organization. It's just an interdepartmental email to send to say like, hey, so-and-so, I'll use you as an example. Micah really needs some help with his Social Security application. He's been camping downtown, said he'll be here until there's a sweep or he gets arrested. So if you can make it down there tomorrow to check in with them, I think it would be a really great fit, and so then our case managers say, all right, let's send our outreach team to go talk to Micah in his camp tomorrow. So we try to find ways to really get folks connected to those services. And part of that referral, whether it's to another Whitebird program or another community provider, is giving context and information to empower folks. It's really scary to reach out and ask for help in the first place. But if I can tell you that, when we go to the drop-in center where you can get some food, take a shower, and do some laundry, Adam's working intake. He's a nice guy. He usually wears a blue shirt. So look for the guy with the blue shirt and a beard. That's Adam. He's going to walk you through some paperwork. There's a couple of forms that you need to sign, and then you should be able to hop in the shower right away, right? We've given some context. That person feels empowered. There's somebody that they know to look for and ask for by name when we get to that facility. And that's just part of really, allowing folks to kind of get to the heart of what it is that they need without telling their story again, without trying to figure out how to interact with a system that might be, new to them.
Thank you so much, Tim. Adam, did we have a couple of questions from the chat?
We do. Let's take this one from Kara. Kara writes to semi-tag onto Vanessa and Micah's questions. How vested or invested is the city of Flagstaff in adopting the CAHOOTS model? In other words, are we examining a strictly crisis response intervention model or more fully adopting and as necessary adapting all CAHOOTS programs into our continuum of care, including, for example, the alternative housing models? Kara, thank you for tuning in and thank you for weighing in. I can't speak for the entire council, but I know that we have declared a housing emergency and we understand the housing crisis and emergency that the community is facing. So I think that we are taking on different angles and aspects of what CAHOOTS and Whitebird Clinic does. It's a little different given that it's not just one agency doing everything. I mean, it's the city of Flagstaff, but I'd say we're very interested in these different topics, and it's kind of being pieced together. I guess hopefully that answers your question. And Kara also asks, does CAHOOTS still operate using the LIN, least intervention necessary model?
Yes, we always have. That was when like I said, introducing myself, I started with the program in 2010, and on my very first ride-along as part of my interview process, before I even got offered the job, I sat down in that observation seat. The driver turned around and said, all right, least intervention necessary. You know what that means? If you don't, you're going to have it figured out, by the time this shift is over. And that has been, least intervention necessary has been at the core of everything that CAHOOTS has done since our very beginning. Again, like I said about that idea of inflicting care, right? We need to recognize that the person experiencing a crisis is an expert. They know what works for them. They know what doesn't, right? They live that day in and day out. We're coming in as outsiders, and we need to listen to that. And part of that, response, part of listening and maintaining that perspective that you in crisis are the expert in this moment, means that we should not be pursuing interventions or, actions that are contrary to what the person is saying is going to work for them or what they're asking for in that moment. It also means not making promises and trying to work on something that's bigger than what we can really work together on right then and there. If somebody is calling us because they're experiencing crisis around eviction and relapsing, we can't handle the eviction process, right? That's something that's going to take lawyers, and that's a process that we can't handle. But when it comes to that relapse in that moment, if that person needs a supportive access to sobering, right, we can work on that right then and there. So some of it is really understanding where we can actually have impact for somebody in the moment, what's appropriate for us as first responders to handle, and where do we need to be working with an individual to identify other resources out in the community.
Thank you for that. Vanessa asks, where do the funds to implement come from in other areas? I'm guessing, Vanessa, you're speaking of other communities that have implemented similar models. That's what I take away. Tim, how would you respond to that?
Yeah, we've seen in other communities, generally speaking, funding has come from new tax revenue rather than reallocations of existing funds. Olympia, Washington, voters approved a public safety tax levy that went to fund mobile crisis services when they got their crisis response unit up and running a few years ago. Denver, Colorado, we saw something really similar. Even up in Portland, as a community safety tax initiative that got some of their funding available. Outside of tax revenue, Senator Ron Wyden's office is really looking at Medicaid as a viable funder on a national, for us on a federal level. But we are starting to see more and more states consider ways to use their general funds to address this. In the state of Oregon, there's Senate Bill 2417, which was approved last month. And by declaring a mental health state of emergency in this Senate bill, funding was made available to bring mobile crisis services in the parts of our state that don't have those systems in place right now, but also fund shelters, crisis centers, and sobering facilities, because those are really necessary components of any crisis response system, regardless of what it looks like. So, state general funds, taxes, Medicaid, there are a lot of different options out there. Even, private foundations could be considered, especially in pilot phases.
And this individual writes, Flagstaff to myself, who is working on getting this funded? Well, I am. Members of the city are, and we've talked about this in our last budget retreat cycle last year. So basically, we've allocated some $750,000 per year for the first 3 years to do an outreach alternative model similar to CAHOOTS, in partnership with Teros, a local agency. And maybe I'll try to do a follow-up live stream with Teros, with the community, so we can talk more about that as well. But that's coming out of our general funds, along with the Prop 207 funds, the marijuana tax. Those monies are to be utilized for first responders. And so we're taking those monies and putting it towards this alternate response effort. As Tim mentioned, they have a detox facility center that they work with that's provided through a nonprofit in Eugene. And we don't have that, to my understanding, here in Flagstaff. I know the Guidance Center offers some detox, but we could use more, is my understanding. So the city is exploring alternate care center as well to complement the alternate response. Let's keep going on these questions as we're running out of time here. Wendy writes, are sobering rooms available as an alternative to ER visits in Eugene?
Yes. And so that's, where I've talked about sobering and detox. If we encounter somebody on CAHOOTS as part of our response, and, intoxication is the kind of primary issue that we're addressing with that individual, CAHOOTS teams, mobile crisis teams can take somebody directly to a sobering facility. And so that means that, we're not stopping and saying, okay, you need to go to sobering, so we're going to, call an officer to come in and take you over there. We're able to do those directly. And that is a really viable alternative to the emergency room. It's really only if somebody is so intoxicated that they're not even able to kind of meet the standard of self-care for the facility that we might end up still taking them to the ER. But that's like, if you can't stand up without falling down and smacking your head, you need to go to the ER. But yeah, sobering beds are a very frequent, referral and outcome of a CAHOOTS intervention.
Kelly writes, meeting a person where they are. And I love that about your model, Tim, and what you all are doing. And from your website, your vision, Whitebird Clinic provides compassionate, humanistic healthcare and supportive services to individuals in our community, so everyone receives the care they need. And then under your values, it writes, Whitebird Clinic's core values are compassion, client-centered care, community focus, individual empowerment, and service accessibility. I just love that approach, and I think it's very appropriate in being successful. Mark and Laura write, Tim, without robust programs fully in place, what do you see is the greatest benefit a model unit, EMT, and social worker can provide until more programs, processes, or a care facility is established?
Yeah, that's a really great question, because as I say, whenever I'm talking about this, it's the other services that allow us to be as successful as we are. I think one of the greatest benefits just of having that response is that it's somebody other than law enforcement who is responding to, myriad situations that historically have been obligated to a criminal enforcement perspective. That means that even if this is probably still going to result in a trip to the ER, because that's where the next higher level of mental health services are. That if that's happening with a crisis worker and an EMT in a van as opposed to a uniformed officer, for one, there's not an armed officer responding to that situation. There's less potential for violence from the responders. There's more opportunity for a humanistic experience, right, and better advocacy if somebody is still going to be going to those most traditional systems of care like the hospital. There's a lot that we do that doesn't result in transport to any other facility. It's really just going out and listening to somebody. Only 60% of the folks that we see on a daily basis are experiencing homelessness. So that means that there's another 40% that have some sort of stability in their shelter and are really calling us in because they need somebody to really listen and be that empathetic ear to support them as they get through a tough moment. And so there is still a ton of value in being able to show up for people in the way that they need, with a first responder that's designated to take these situations that aren't a medical emergency and that aren't criminal in nature.
Thank you, Tim. And we're hopefully wrapping up in the next couple of minutes. Daryl, are you with us? Can you hear me? Let's see if we can get Daryl in and maybe asking a question. Daryl, are you able to unmute yourself? I know he's having a little bit of technical troubles.
While we're waiting for Daryl, I just wanted to ask a question that's been posed to me a couple of times. Specifically, how do you guys interact with the undocumented or immigrant communities in Eugene? That is a particular concern all across Arizona, especially in northern Arizona. How do you make them feel safe contacting emergency services?
Yeah, we're not doing a very good job of that. Is the best answer I can give you. As I mentioned early on in the presentation, the way that our system works right now requires enough privilege to feel safe calling the public safety system. Absent an alternative way for folks to access CAHOOTS services, we've had to try and get creative. One of those is making sure that we have staff members who are primarily responders, but who also serve as liaisons and ambassadors to our community to really address that inaccessibility. And when we, specifically are working with, undocumented communities, where we have found the most success is collaborating with organizations that are serving them in other ways to talk about what's a safe way to access us. Is it that maybe the service provider needs to call and do an anonymous request and say, hey, we need CAHOOTS for counseling, really vague, at this intersection, and the van shows up at that intersection, and somebody comes out and flags us down, that way they're not giving information about a specific address or specific individuals to dispatch. But going beyond that, we have formed a community advisory council to help us be better. at that, because every idea that we've come up with is our idea as a predominantly white organization, and so we're trying to really take the time to listen to our community, so that we can do better. I think something that's going to be a big sea change for us in the coming year is the implementation of 988. 988 as a kind of a nationally recognized crisis number, is a really powerful opportunity for us to shift our point of access away from such a direct connection to law enforcement, and put us more into that space of behavioral health first response.
That's great. Thank you. Daryl, are you with us? Okay, we'll take this next question. Yeah. Oh, Daryl, welcome. Do you have a question for Tim?
Not at the moment, but I'm formulating one. So.
Great. Well, thanks for joining us. What's Tim's assistance? No Cap Phoenix was developed here in Phoenix last year. With Tim's assistance, yeah. Sorry.
Yeah. We've been talking with folks in Arizona, in Phoenix, and honestly, No Cap is a really awesome example. In particular, I will celebrate their work, and I'm not going to take credit for this at all. One of the things that No Cap did in Phoenix, and I would encourage you all to do, is develop a set of guiding principles. What is it that is the foundational things that any mobile crisis service in Phoenix is going to do, going to be, right? And really taking the time to drill down on the community input to get to that point, where, yes, as Kara says, right, your crisis is not a crime, right? And so creating this framework that says, these are the things that make our service what it is. These are the things we're going to accomplish. We have been, with their permission, singing the praises of No Cap and sharing some of their guiding documents, with other groups around town. Yeah. In Flagstaff, you guys don't have to look far to find a really great example of a successful approach.
That's great. Thank you for that. How many crisis staff do you employ that are responding to the 18,000 calls?
Mm-hmm. We have a staff team of about 50 responders in total. And at any given time of day, there are going to be 2 to 3 teams that are out taking calls. So that's going to be 4 to 6 staff on duty at any given time.
Tim, we are over on time, and I am so grateful for you and your insight, and I know the community is as well. I have a lot more questions, but we'll just leave it there for today. We'll have to explore options for consultation or more communication with you and your team for our community here in Northern Arizona, as we embark on this journey in trying to better serve our public through these types of efforts. Thank you so much for joining us today and for all the work you do and for sharing those resources with us. We so appreciate it. Micah, thank you for helping us set this up. Daryl, thanks for joining us on the panel along with Jonathan and others. And wishing everybody a great day. Engage with the community, with the council, engage with us as we embark on this journey together. And hopefully we will see a model here in Flagstaff soon that will hopefully not only lead in the state, but in the region as a model of what is to come in terms of how we respond to the call for other communities as well. Tim, closing comments before we wrap up?
No, just thank you for the opportunity, to kind of talk about what we're doing up here. And I have been encouraged every time that I've talked with, folks in planning this. So I'm really excited to follow the progress and hope to, be a part of the work in the weeks and months to come.
Great. Thank you all so much and have a great day.
Thank you so much.
Bye, everybody.